Finally, to round out this training session, we will provide some clinical scenarios that may help to reinforce some of the differences between PAV Plus and pressure support ventilation. Here is a screenshot from a simple, uncomplicated patient breathing on pressure support with reasonable efforts. Let's see what happens when we switch this person to PAV at 50% support. On the left is the last pressure support breath, followed by the first PAV breath. You can see that there are inspiratory holds being done throughout the PAV startup, and these are indicated in white. This is how PAV Plus obtains the starting average values for compliance and resistance over at least 4 breaths. You can also see the compliance, resistance, and intrinsic PEEP data displayed at the top of the screen, as well as the work of breathing bar near the bottom of the display. The flag indicating work of breathing done by the patient is on the left of the bar, and the work of breathing total is displayed at the right of the bar. The shadow trace in blue that is displayed during PAV Plus ventilation shows the estimated alveolar pressure throughout each breath cycle and is used in determining intrinsic PEEP. Even though this was a relatively routine transition from pressure support to PAV, you are still likely to see more variation in tidal volumes during PAV ventilation due to natural biovariability that may be masked during pressure support ventilation. In this scenario, we have a moderately distressed patient that appears to be making strong respiratory efforts. Because the patient is already looking distressed, a clinician may decide to try to transition to PAV at 75% support instead of 50%. You can see that as soon as PAV is started, the high pressure limit started sounding, and shortly after, the PAV Plus startup too long alarm sounded as well. The patient is clearly not tolerating this transition. So what is the issue here? Remember that this patient appeared to be making strong efforts, and also recall that at 75% support, the PAV Plus algorithm will amplify patient effort by 3 times. In this case, the patient's effort was roughly 12 centimeters of water, and when that was multiplied by 3, PAV was supposed to deliver 36 centimeters of water pressure above PEEP for a peak airway pressure of 44. This violated the high pressure alarm limit, so the plateau maneuver in the PAV startup couldn't be completed. This is what caused the PAV Plus startup too long alarm. Simply changing to a lower percent support setting, in this case 50%, was adequate to get through the PAV startup, and then we were successfully able to increase percent support to 75% while allowing the patient's efforts to drop to more reasonable levels. Note that a very similar situation can occur with the high inspired tidal volume alarm, which will also truncate the delivery of a PAV breath if exceeded. A key point is that you want to make sure you set the high inspired tidal volume alarm and high peak pressure alarms appropriately, and then use an appropriate amount of support for the degree of patient effort during the startup. This next scenario depicts a patient that seems to be tolerating pressure support very well and looks extremely comfortable with good tidal volume and respiratory rate. Typically, we would have no idea that there may be a hidden underlying issue that has the potential to significantly prolong this patient's length of stay. As we transition to PAV, we can see that while the last pressure support breath on the left looked normal, the first PAV breath is showing that the patient has been making extremely tiny efforts. The minimal amount of respiratory muscle effort while on pressure support for this patient could be enough to significantly atrophy the respiratory muscles, which could have led to a prolonged series of failed weaning attempts had PAV not been implemented early enough to notice this issue. In this case, no additional intervention was required after the patient transitioned to PAV. Over the course of the next minute, the patient's effort stabilized within an acceptable range, and the patient remained comfortable. Having a keen eye and some skill at reading waveforms will help you with this next scenario. You may notice that every second effort on this patient is being missed. Looking closely at the patient's chest, you can confirm that they're actually attempting to breathe at a rate of about 36 per minute. Immediately after this patient was transitioned to PAV, the total frequency increased to 38. However, very shortly after the transition, the frequency fell to about 30 as the patient was feeling less anxious due to improved synchrony. Despite the higher respiratory rate on PAV than on pressure support, the patient still looks comfortable and does not meet any criteria that would indicate impending respiratory failure. Higher respiratory rates are not uncommon when using PAV Plus and are typically the result of the patient being able to attain the frequency, tidal volume, and breathing pattern that their respiratory center desires without the asynchrony and potential oversupport that is possible in pressure support. In this next example, we have very normal looking ventilation in pressure support. Patient looks very relaxed with a normal rate and tidal volume and appears to be tolerating current settings well. After transitioning to PAV, see that the rate is very high and tidal volumes extremely low. Cardiac oscillations had been triggering the ventilator all the time, but it was difficult to see this was happening in pressure support, but quite obvious with the switch to PAV. Here you can see where we asked the patient to take a deep breath in, and they clearly were able to do so, but they still had no real drive to breathe after that single breath. A quick look at blood gases showed that the CO2 levels were on the low side and the patient was slightly alkalemic. After correcting the flow trigger to stop cardiac triggering, and then simply monitoring this mostly apneic patient for a couple minutes while waiting for the CO2 levels to rise, a normal respiratory drive kicked back in and the patient continued to ventilate nicely on PAV. Key point to remember is that cardiac oscillations can trigger the ventilator in pressure support and look like normal, comfortable breathing. However, it is immediately noticeable as a problem in PAV and can be corrected appropriately. As you get more experience using PAV, remember that there are significant differences between the way that pressure support and proportional assist ventilation respond to patient efforts. Pressure support will continue the inspiratory phase until the esensitivity flow termination criteria is met, regardless of when the patient's effort actually ends. However, PAV will only support the patient for the duration of the respiratory effort. This difference means that a patient making a tiny effort in pressure support may meet their ventilatory demands and continue making tiny efforts, whereas the same tiny effort in PAV may result in much smaller tidal volume, forcing the respiratory center to increase effort on the next breaths. This, along with adjustments to the percent support setting, may allow a clinician using PAV to better target a normal patient effort level with the goal of preventing further diaphragm injury. However, if this patient is too weak, too exhausted, or too atrophied to generate an adequate respiratory effort, they may appear to have more severe respiratory distress with PAV, even at elevated percent support levels. While the same patient may look fine on pressure support, continuing to use pressure support and allowing a tiny respiratory effort may continue to damage the respiratory muscles. In these cases, where even high levels of PAV percent support seem inadequate, consider resting the patient overnight, possibly on pressure control, ensuring that absolutely no distress or accessory muscle use is noted, and try PAV again the next day. It may take several days of trying for such a patient to tolerate PAV for long enough to get started on the prolonged weaning protocol. As we conclude this session on the use of proportional assist ventilation with prolonged weaning patients, keep in mind that this session is not a replacement for reading and understanding the PAV Plus sections from the PB840 or PB980 operators manuals. In summary, keep in mind that this session is designed to prepare you to use PAV Plus as it pertains to the prolonged weaning protocol established by Royal Columbian Hospital. Increasingly, PAV is being used earlier, even in the acute phase of critically ill patients, with the goal of improving patient ventilator synchrony and preventing harmful diaphragm changes that are associated with prolonged mechanical ventilation. For more information on the acute use of PAV in such patients, as well as on the potential physiologic benefits of doing so, please contact your local Medtronic Puritan Bennett ventilation specialist. Thank you very much for your time.